Hey guys, welcome back to St3 Hacks, and today we've got a big episode, which is that of the open fracture. Now, this is a very common ST3 case, and I'm sure you've practiced it enough, but I'm going to go through it in a very thorough manner and try and include some golden pearls that may help you differentiate yourself in this station where everyone is really going to be prepared to quite a high standard. So, an open fracture. The pathoanatomy here is that an open fracture represents a communication between the fracture site and the external environment. This is not simply a fracture with a wound, it is a contaminated fracture with variable degrees of soft tissue devitalization, periosteal stripping, vascular compromise, and bacterial inoculation. The key pathology driving outcomes is energy transfer, and higher energy injuries are associated with greater zone of injuries than is visible on the skin, higher infection risk, higher rates of non-union, compartment syndrome, associated polytrauma, and it's crucial that the ST3 level point is that the size of the wound does not reliably reflect the severity of the deep tissue injury. You've got the Gustillo-Anderson classification, which is important to say that's an intraoperative classification, so you can't really quote that, you reviewed this patient ED and then you say it's a Gustillo-Anderson 3A. It's based on findings at formal debridement within theatre. It is noted to have poor inter-observer reliability and therefore should guide communication rather than dictate rigid management decisions. Grade 1 is a clean wound less than 1 centimeters. Grade 2 is a wound more than 1 centimeters without extensive soft tissue damage. Grade 3 is divided into A, B, and C, but essentially is high energy injuries or significant contamination. Automatic grade 3 situations include high energy mechanisms, gunshot wound, heavy or farmyard contamination, open segmental fracture, delayed treatment more than 8 hours, arterial injury requiring repair. Subtypes of 3A is extensive soft tissue damage but adequate coverage. 3B is extensive soft tissue loss with periosteal stripping requiring a flap. And 3C is associated arterial injury requiring repair. For interview purposes, classification is assigned after first debridement and not in ED. Okay, so just remember that. Moving on, there are 4 reasons why the patient may need immediate surgery. Okay, these include compartment syndrome, vascular injury, gross contamination with SAM, so sewage, agricultural or marine. That's my kind of acronym, SAM, SAM. And lastly, polytrauma requiring damage control orthopedics. So these are the 4 situations in which the patient is for immediate surgery. Okay. This should trigger your orthoplastic and vascular kind of input as well as required based on the pathology. Moving on to the radiology. So you want full-length orthogonal x-rays, including the joint above and below, CT if there's intra-articular extension. In high-energy trauma, a CT trauma series would normally be requested, and a CT angiogram if there are abnormal pulses or high risk of suspicion of vascular injury. Key concerns. All patients here should be managed by ATLS principles, as these are frequently high-energy injuries, and you want to say I would be particularly focused to rule out neurovascular status, soft tissue envelope, risk of compartment syndrome. Because this pattern of injury is high risk for compartment syndrome, I would avoid regional anesthesia that could mask evolving pain unless discussed carefully with anesthetics. And that kind of shows you're a bit snazzy and aware of what really could go wrong with these patients. Guidelines. Management should follow BOAST guidelines for open fractures, and this clearly outlines that in the initial ED management should include IV broad-spectrum antibiotics within 1 hour, tetanus prophylaxis as indicated, removal of only gross contaminants, photograph the wound, cover the wound with saline-soaked gauze and an occlusive film, realign and splint the limb, document neurovascular status before and after manipulation. Patients should be transferred early to a specialist orthoplastic center, i.e. a tertiary trauma center, if not already in one. Timing of debridement. Now, BOAST emphasizes urgency based on injury characteristics rather than the old 6-hour rule. So immediately, if there's compartment syndrome or vascular compromise, within 12 hours if they're high energy injuries, and within 24 hours if they are low energy injuries. Now, definitive soft tissue coverage should normally occur within 72 hours of the patient coming to the hospital, and this reduces infection and non-union risk, and hence early orthoplastic planning is indicated. Your triple assessment should be as usual, so your history, mechanism of injury, time of since injury, ample history, diabetes, smoking, vascular disease, any previous surgeries, any social factors which may affect rehabilitation, examination, your neurovascular status, distal to the injury by palpating the pulses and the capillary refill time and using a Doppler to check your DP and PT pulses, looking ideally for a triphasic flow. You test the motor and sensory supply of the superficial and deep peroneal nerves along with the tibial nerve, and you palpate the leg compartments and ensure passive stretch is not limited to ensure you rule out compartment syndrome. And serial examinations are quite useful as you want to monitor these patients. Moving on to investigations, you want your trauma bloods, FBC, UNE, CRP, cross-match, group and save. You should also highlight here CK, especially if there's a crush component to muscle injury. And moving on to your management, the primary surgical principles here are meticulous debridement, skeletal stabilization, and early soft tissue management. The aim is to restore length, alignment, and rotation, allowing secondary bone healing where appropriate. And definitive fixation may include external fixation, often in initial damage control orthopedics. And then, you have the options of intramedullary nailing, ORIFs, and circular frames. Now, you can be asked in the interview, if you've reached this point, that how would you perform debridement? So you should reel off this statement. Assuming the patient has been managed appropriately in ED as per BOAST guidelines, I'd ensure to confirm consent and the WHO checklist. I'd ensure supine positioning, full prep and drape as per protocol, use a tourniquet cautiously, often deflated before final assessment of tissue viability. The aim is to, systemically excise or devitalize tissue. I would extend wounds along fasciotomy lines where required, debride methodically from superficial to deep in a clockwise manner, working circumferentially to avoid missing any devitalized areas. I would assess muscle viability and tissue viability by the 4 C's: color, consistency, contractility, and the capacity to have capillary bleeding. For bones, I would deliver both fracture ends carefully, remove any loose, non-viable fragments without soft tissue attachments, and I would assess for fresh bone healing, which is often mentioned as the paprika sign. I would use low-pressure saline lavage, typically in staged volumes, recognizing that excessive pressure may drive contamination deeper, and volume is guided by contamination rather than any rigid rules. In terms of application of your X-Fix, if there is, it's indicated in this case, in unstable, highly contaminated injuries, you can say you would apply a spanning external fixator. And the principles of this, although we'll discuss this properly, are that pins are placed outside the zone of injury in a near-near, far-far construct, and you want to restore length, alignment, and rotation, and confirm this with intraoperative image intensifiers. This allows soft tissue reassessment and staged management. For closure, the wound is usually left open after first debridement, and options include a negative pressure dressing or a standard dressing plus or minus pico. There is a study here called the WOLF trial, WOLLF trial, which demonstrated no clear superiority of negative pressure wound therapy over standard dressings in severe open lower limb fractures. A planned second look operation is usually indicated around 24 to 40 hours, which is common practice. I'm sure you've all seen in your trusts. Definitive closure or flap coverage should occur, as I said earlier, within 72 hours where feasible. Okay.